Hi, I'm Dr. Jared Gardner, and I'm here today with my two awesome Dermpath Fellows, as well as Derm residents and Path residents. We're going to look at some unknown cases. From this power, what's this look like? Here's skin up here. I guess we can turn it right side up, huh? Yeah, lymphoid, right? Looks kind of like a lymph node, although what's it doing down here in the deep dermis / subcutis? So, but I like that actually, and the reason that's important is when they got a beautiful ring like this, who cares, right? You don't pay attention to the foam, but sometimes they don't look this perfect, and what you get is you'll get a little like kind of slightly multinucleated thing cut at a funny angle, and recognizing the foam around the cluster of nuclei is a clue that you're dealing with a two-ton giant cell, even when it doesn't have that perfect ring shape. Now that I'm saying that, I of course will not be able to find any because all the two-ton giant cells here look really good. Oh, like that one. See, at first glance, you may not be inclined to think that's a two-ton giant cell. It doesn't have a perfect ring, but it's got a ring of foam around the outside. See? So that tells me it's a two-ton giant cell, even if I don't see that perfect ring of nuclei. And then look what we also have here. How convenient. Eosinophils, yeah. And to anyone watching this online, I apologize. The camera I'm using at this particular multi-headed scope is not the same as I use for most of my videos, so the quality is not quite as crisp, but hopefully it will suffice. All right. And if not, you can give me a thumbs down, and that'll be okay too.
Probably better mimics testing conditions.
Yeah, that's true. That's true. Yeah, we did this intentionally. It's for your own good. All right, good. I like that. Thank you. That was perfect. I'll give you that $50 later. All right, so. All right, so what do we have then? Two-ton giant cells, histiocytes, a little bit of lymphs, and some eos. Someone already said it, right? Yeah, xanthogranuloma, juvenile xanthogranuloma, or JXG, or the other name solitary xanthogranuloma, because they're not always in kids. Adults can get them too. They're also not always solitary. Sometimes people get multiple, and you can even have them eruptive. We reported a case of eruptive xanthogranuloma in a healthy adult a few years back. It was kind of interesting. So that's a really nice example. And I think one thing I'll point out about xanthogranulomas is they don't always look just like this. They can really run a wide range. At one end, they're florid histiocytes with tons of two-ton giant cells and eos. That's the classic. This is as classic as you can get. But they can also be very fibrotic and have a lot more collagen and fibroblasts, and those look kind of like dermatofibromas sometimes. You can also have ones that have no eosinophils, or very few. You can also have ones that have very few multinucleated giant cells, particularly kind of when the lesions are early, when they first pop up. I've seen them, they look almost like a mastocytoma. They have kind of a uniform sheet of cells that are kind of histiocytoid, but have very little foam, no two-tons, maybe a couple eos. And in fact, I remember one distinctly, I was like, oh, surely that's a mastocytoma. It was in a kid. And then I did a CD117C kit immunocyte, dead negative. And I was like, oh my gosh. And then I realized that's what it was, an early XG. So I thought, well, sometimes the best times to learn are when we think for sure we know the answer, and then we're dead wrong. So thankfully, nothing bad came of that, and it was all fine, but it was a good lesson for me, and good humility that I'm going to share with all of you. All right, so let's see what's next. Maybe I can get it unfocused there. Okay, more or less.
Nodule. Seems like there's a lot of kind of clear
here's skin
spaces.
up here. Yeah. So yeah, we're waiting on the subcutis. A lot of clear, yep.
And a lot of vessels.
And maybe. A lot of vessels. And we'll go in a little closer so we can see that on the screen here. But indeed, that's a perfect description. There's a lot of blood-filled spaces, and there's a lot of clear cells.
First thing that brings to mind is like renal cell carcinoma.
Absolutely.
Metastatic.
That's exactly what it looks like to me. They are definitely clear cells, and they're arranged in kind of nests or trabecular kind of shapes. Lots of blood-filled sinusoidal spaces in between them. Renal cells, depending on the grade of them, sometimes they have very prominent nucleoli, not always. And they can also, sometimes they can be really ugly and spindled and even sarcomatoid. I've definitely seen that, sarcomatoid renal cells that are really ugly. So when they metastasize, they don't always look like this. And of course, there's many different types of renal cell. Not all of them are the classic clear cell morphology. But yeah, anytime you see clear cell tumor that's making nests or kind of trabecular structures with blood-filled space in between, metastatic renal cell should be right there on your differential. And of course, there's a long list of other things that can manifest in the skin with clear cell change. I think one of the things that I've seen most closely mimic metastatic renal cell is clear cell hydroadenoma. Usually they are not completely clear like this, but I did see one case once that was dramatically sheet-like, just totally clear like this. And only on further inspection, you could see that it focally connected up to adnexal structures and that it was actually, and then when we did stains, it was P63 positive, which renal cell is not going to be, usually PAX8 negative. And it was actually called metastatic renal cell. And then when they scanned the patient, the kidneys were negative. So then it came in consult to me and I saw it and I was like, oh, but I said, this is definitely the most close mimic I've ever seen of it. It was really dramatic. Picomas of the skin can sometimes look a little bit like this, not quite, but they can look a little. And CD10 will stain renal cell, but it stains picoma and a whole bunch of other stuff too. I really do not find CD10 to be a useful stain. Maybe in hempath it is, but in the setting of dermpath and soft tissue, otherwise I personally don't really find it useful, so I don't use it in my practice really. There, I think we got it. Okay, that's pretty. A little bit faded, but it's really cool.
Acral site.
Yeah, acral, yeah.
We have this nodule in the dermis. Kind of has a looser stroma around it.
Yeah, there's like a space around it, probably partially artifactual, where it's kind of separated from the dermis. And then what about this?
Yeah, it has these nuclei that kind of all line up.
Swoon, that's beautiful. I don't think I can do any more work today. Like some things are just too pretty and you just can't afterwards. You can't focus anymore. Yeah, so what do we call that pattern? Yeah, in this case it is varicate, but what do we call the pattern of the nuclei lining up like that? Just the lining up of like elongated nuclei? We call it palisading, right? Mm-hmm. So palisading can be when it's in a schwannoma, we call it a varicate body. But you can have palisading in lots of different stuff. And that's a good example of it. So very nice example of palisading. And my co-fellow, Toby Foster, I've said this before, but he had this, I've heard a lot of analogies, like, you know, some people say it's like a flock of birds or it's like all this, but he said it's like you have a pile of leaves on the floor and you take a broom and sweep them back and forth into two piles and leave an empty space in the middle. That's a varicate. And I was like, Toby, you're brilliant. He is from like North Georgia, has a real strong Southern accent. So he always had like all these folksy wisdom sort of sayings. And I thought that is like the, you know, everyone has a different visual analogy, but some of them really resonate. And I thought that was perfect. I thought that's exactly, it's like you swept two piles of leaves. So if anyone out there is listening to this and knows Toby Foster, tell him I said hi. He's one of the smartest dudes I've ever known and a great co-fellow. I had a wonderful year at Emory training with him. I learned a lot from him because he'd been in practice for about 5 years and then came back and did fellowship. He was in the military. And so he knew a whole bunch of stuff about practical daily practice. So I learned a lot from the questions he would ask our program director and our faculty. So schwannomas, there's a lot of different things. The palisading is really helpful. You don't always have that though. And they do usually have a thick outside capsule. And a lot of times you'll get hyalinized vessels. I'm trying to see if we have that here. Not really. We'll tell you this though, that not everything that palisades is schwannoma. Melanomas can palisade, lots of stuff can palisade. And the other thing is that when you're in the skin, it is very, very rare to have a schwannoma in the dermis, in my experience. I'd say usually what I tell people is if you think it's a schwannoma in the dermis, it's probably a palisaded encapsulated neuroma because it's like 1,000 times more common than schwannoma in the dermis. I see schwannomas all the time, and I think I've got like a couple recuts of ones that are actually in the dermis. I've seen them occasionally in the subcutis, but usually they're subcu or deeper most of the time. Pretty uncommon to have a schwannoma in the dermis in my experience. So always think about other things, and there are a variety of other features, and I've got a whole long video about schwannoma. I'll put a link in the video description down below that shows many different examples and all the variations thereof. So let's see what this was called. They called it a schwannoma on the finger.
Wow.
30-year-old. Pretty nice. I bet this is also from the finger. I might be wrong. We'll find out. So we're doing a random unknown set here of things that were contributed from a recut exchange club that I'm in for teaching. So,
well, obviously there's a big, like a large proliferation in the derm, or
in the where? That's the question. Where are we? Yeah.
Maybe near
There's nothing normal, like there's not much normal around, right? There's a little maybe fat or loose connective tissue there, but there's no adnexal structures, there's no epidermis. So when you have a nodule that's shelled out with nothing attached to it, usually that means you're in the subcutis or thereabouts, okay? With the exception if it's a general surgeon in the abdominal cavity, well, then anything's possible. But anything that's coming out from like a dermatologist or someone who's doing an in-office procedure, if they pluck out a nodule or something and no muscle comes with it and no epidermis comes with it, it's probably in the subcutis or right around there or on the fascia, because otherwise you wouldn't. If it's in the dermis, you're going to take out epidermis with it. If it's down below the fascia, you're going to surely get some skeletal muscle that comes out with it. So that's one thing that gives me the clue. The other thing that I think we're on an acral site, because look how ratty and ragged it is on the edge. I feel like hand and foot surgeons, rightly so, I assume that this is because they bluntly dissect and tried to do their best to really be careful about not removing any extra tissue. So I feel like the edges of specimens from the hands and feet in the soft tissue often are kind of frayed and ragged, because I think they're trying to spare and make sure that they don't take out any of the vital structures there that are needed for, movement of your fingers and your feet and stuff. That's my theory. Also, probably the tissue there is a little different. And then also we see this right here, dense pink stuff. It's dense regular connective tissue. Probably it could be fibrosis in the tumor, but it's probably, to me, suggests that we're coming off of tendon sheath, or fascia, something like that. Okay.
Giant cells.
Oh, indeed. Good.
Multinucleated.
And you know what? You can see them here, but even at low X, when you know they're there and you know to look for them, you can see these big blobs that you see there. Okay, well, maybe we can focus. These big blobs you see there, those are giant cells. Yeah. Now let's go closer and look around and see what else we're dealing with. We've got giant cells, and in addition to the giant cells, these background cells, these kind of uniform, big, plump mononuclear cells. I get them to stand out there. A lot of them, they got kind of grayish cytoplasm, and they're eccentric. See how they kind of have a nucleus at one side, so kind of almost gives them a plasmacytoid or rhabdoid kind of appearance, if you like. That's the term that resonates with me. Sometimes they can be binucleated. They can be kind of big. I mean, some of these guys are big, right? And guess what? If we look around, we'll find, I think it's a lymphocyte there, but we'll find mites. There are often a good number of mites in this tumor. So we've got these uniform histiocytoid cells that have a kind of eccentric nucleus. There's a mitosis. We've got multinucleated giant cells. Now, these don't look like Teuton giant cells, do they?
No.
When all the nuclei are kind of clustered in the middle, to me, that's usually an osteoclastic giant cell, okay? And that's what these are, osteoclast type giant cells. We've got dense sclerotic collagen in the background. Looking for the other things, all the keys. They're not all of the features are always present, but maybe here. Just a little bit. There's a little bit of foamy histiocyte there. See that? It's a little bit subtle. But there's a touch of foamy cytoplasm in some of the histiocytes. And the other feature, the two other things I was looking for were discohesive pools of cells where they all fall apart. That's a real nice feature, but we don't really have it here. And also hemosiderin. And I'm not really seeing much of that here. So what's the diagnosis?
I'm hoping it's giant cell tumor.
Yeah, it is. It's giant cell tumor of tendon sheath, or Tenosynovial giant cell tumor localized type. Is it the name for that? Often occur on the hands and feet, although occasionally you can get them in the larger joints, like more proximal. The diffuse form tends to occur in the larger joints more often, though, which is sometimes called pigmented villonodular synovitis when it gets into the joint space. And it usually occurs like in the knee, whereas giant cell tumor tendon sheath usually occurs in the distal extremities, but I've seen exceptions both ways. And up close, those tumors look identical, or can. At higher power, it's only their low power growth pattern that sets them apart. So they all both belong to the family Tenosynovial giant cell tumor. All right. These are important to know about. And the reason I went over all the other features, you're like, well, the giant cells are there, but the problem is they don't always have giant cells. Sometimes they have very few or no giant cells, and those can be really challenging to diagnose because all you see is these sheets of big, plump histiocytoid cells with multiple mitoses. And guess what? These things can be hot on PET scan too. So I've seen them show up at the time of frozen section because they were a PET hot nodule in a patient who had cancer, and they were doing a PET CT as a screen to scan, and they happened to notice one of these, and then you see epithelioid cells and mitoses, and before you know it, you can get yourself in trouble. So that's when, and I remember one frozen I saw like that, and it didn't have giant cells, but it had a little bit of foamy histiocytes, and it had some pigment. And then I was like, oh, I wonder if this is a giant, and it was on permanent. So that was helpful. And also other things can have giant cells too. So that's why it's helpful to know all the extra background features. And I do have a full-length video on that too. So I'll put links down below. And you guys, I can send you an email with them or whatever. giant cell tumor tendon sheath, Tenosynovial giant cell tumor localized type. Okay.
So it looks like we have this diffuse dermal, looks like probably all lymphocytes or
It's all something blue, right? I mean,
something blue. There's a granulome at the top.
yeah, that's true. There is. And I often talk about how I don't find the granulome very helpful, but every once in a while it comes in handy.
Some of them are kind of forming nodules, so you question if there's terminal centers in there, but maybe not quite.
Yeah, hard to tell. You're right. From lower power, it gives the impression that there could be a few nodules, but overall it's pretty diffuse, I think. Yeah. But yeah, that's always a good question. If there's a vague nodularity, to wonder could there be germinal centers or something else going on. I can't quite, having trouble getting this camera to focus, but oh well. Yeah, pretty large, pretty atypical. I saw some mites in another field. May not be showing up real well, but so yeah, what you still thinking something lymphocytic or
Yeah, probably some lymphoma.
okay?
In that same category, I would always try to think about pseudolymphoma.
Mm-hmm.
And them being so large, granulome, you then kind of think more B-cell lymphoma.
Good. Well, I'm not the person to teach you too much about lymphomas because I still find them hard. And even when I think, oh, I think I got this one, it ends up being some double hit, weird variation. So I just let the heme paths mess with this stuff. It's out of my league. But yeah, diffuse sheets of blue cells without any like kind of cohesiveness, either they're discohesive or completely just a uniform sheet, is a good idea to think of something in the lymphoid or hematopoietic, right? So lymphoma leukemia if it's really atypical. So that's kind of where I would be looking at this. I'd say it's either like a high-grade lymphoma, like a large B-cell lymphoma, maybe leukemia cutis, although that tends to have a little bit different growth pattern, but it can overlap. You know, if you can think of like CD30 positive, that's a type of T-cell thing that could be ugly, but although those usually look even more dramatically ugly, more cytoplasm than this, I feel like to me. Blastic plasmacytoid dendritic cell neoplasm, I always feel like those I never can quite recognize them on their own. I always have to try to keep in the differential. So you would do an immunostain workup accordingly. And I won't go far into that because I feel like it's very nuanced and outside of my normal spectrum. But I imagine that's what this would stain like. So let's see what they said. And this was diffuse large B-cell lymphoma. And no more information is given than that, but that is, I think that's compatible with other diffuse large B-cell lymphomas I've seen, but yeah, you would need to do immunostains. And then there are molecular testing and stuff that they'll do beyond that to help sort out what type. Oh, that's fun. Even from low power, we can see when we flip the condenser, something happens. Look at that. See how those things change color like dramatically when we flip the condenser. What's going on there? It's a great example.
Bodies.
Good. Where do you think we might be?
Mucosal site?
It looks like squamous mucosa to me. There's no granular layer. There's no corneal layer. Don't see any adnexa yet. And we've got these round, very like round nodules here, some of which are kind of falling apart. And they're surrounded by what?
Granulomatous inflammation.
Yes, exactly. There's giant cells. And when we go very close, you can see that the individual nodules are not one structure. They're like a round collection of tiny little refractile particles. And there, when we flip the condenser, you can really see the refractile nature of it standing out. So I'm flipping the condenser and focusing up and down. That helps to get three-dimensionality. And then let's see if we can polarize this. We'll give it a try. It doesn't always work. It doesn't always pick up on the camera, but we'll try it. No, not really, huh?
Hmm.
Well, not all foreign material polarizes, and I can't always remember which ones do and don't, so that's why it's worth trying. Also, sometimes foreign material that comes in, like I saw a case not long ago, it was non-polarizable, but it had little tiny bits of polarizable stuff mixed in it because if it was a penetrating injury, you know, sometimes you'll get a variety of particles stuck in. So not all of them might polarize, but you might find some that do, and that sometimes you need to go close to find that. But here, I think this is, do you know what this is, anyone? It's very distinct if you've seen it before.
Filler.
It's filler.
Calcium hydroxylapatite.
Yes, that's exactly what it is. It's calcium hydroxylapatite. It makes these very distinct spherical looking structures that are filled with granular whitish refractile particles. And see, the reason that they look like they change colors at first is because all the extra space in between when you flip the condenser from lower power, it makes them look like almost black on the screen. And here we can tell that it's just that it's refractile, but it's hard to get that to pick up on video. But yeah, this is a real distinct pattern. And there are various papers about all the different types of fillers. And I don't know all of them, but this is one that I think stands out to me a lot, is the calcium hydroxylapatite. Very nice. And it's just completely filling up the whole dermis or submucosa. I don't know what it is. When I get near mucosal sites, I never know. So sometimes I'll say the epidermis slash mucosa shows this. The dermis slash submucosa shows this because I don't exactly know what the right term is. Well, that's something dark brown.
Pigment.
Yeah. Oh, and there's more. Okay. Some brown pigment here. What kind of cells do you think these are? Yeah, I think these are all melanophages, right? Now, you could argue, well, some of them, you know, the nuclei have a little bit bigger nucleoli in there. Could they be melanocytes? They don't really seem like it to me because, you know, melanocytes, I don't know. I feel like they're kind of spaced out a little more than I would expect. Melanocytes, I'd expect there to be some nesting at some point or kind of clumping together. Or when you get like some melanomas that are really ugly, you just a few sheets, but they're like packed close together. So I feel like here we've got a bunch of melanophages with a bunch of background sclerotic collagen, some scattered lymphocytes. There's a lot of vessels. See all the vessels here? And then here's kind of more normal collagen out here, but I feel like the collagen and everything's altered here, and we just have a ton of melanophages and no obvious melanocytic neoplasm that I can see. Although in real life, I would probably stain this just to be sure, because also sometimes even when you think it's all melanophages, you could have actually some viable melanocytes in the midst of it that you're missing because of all the pigment. It could obscure it. So you could try doing a red immunostain like SOX or something like that to see, or a MART maybe. So what would you do with this? If we did say we did a stain and it's all negative, then what would you think of?
No.
Yeah, to me, it looks like, at least I've not checked the answer here, but it looks to me like a good example of tumoral melanosis. And that's when, for the junior folks watching this, what you get is a melanocytic lesion that completely regresses. The immune system wipes it out, and what happens is all the pigment deposits. I feel like you see that most often with melanomas, although theoretically you can see it in association with other types of melanocytic lesions. And the problem is when I see this, I can't say for sure what the original melanocytic lesion was. I can just say this is consistent with the regressed melanocytic lesion, and there's no residual melanocytic lesion here to classify. But I feel like in general, you got to consider that this patient might have had a regressed melanoma. The times that I feel like I've seen this most often is people who had a melanoma that metastasized to like a lymph node, and then I feel like it kind of revs up the immune system, and then it goes back and destroys the original primary. At least I feel I've seen a couple cases where I assume that that's what happened. I don't really know. There's no way to really know for sure. I've also sometimes seen Mets that like metastasize, and then they kind of with treatment or something else can kind of regress away. One thing that you can see sometimes though is when you do, if this were the primary melanoma, when you do there's a little giant cell granuloma there. I wonder if that's significant. If you do a melanocytic immunostain, you'll find that the normal background melanocytes are oftentimes wiped out too. So the body's immune system destroys the melanoma cells, but also will destroy the normal intraepidermal melanocytes. So sometimes that can be really helpful. If we see a big zone where there's no melanocytes at all, and there normally should be scattered melanocytes in the epidermis. So if we see that there's all gone, then that always makes me really concerned. Maybe there's some regression going on. It doesn't always work perfectly, but I've seen some cases where it worked real nice. So, all right, let's see what they said. This was called tumoral melanosis, 30-year-old male that had a history of melanoma, and this was negative for MART1 and positive for histiocyte markers. That's a really good example of tumoral melanosis. I've also seen sometimes melanomas that have like a zone of tumoral melanosis, but still have some residual viable melanoma present too, like from real prominent regression.
Well, we have kind of an acanthotic epidermis, and there's an ulceration off to the side.
Yeah.
Some pus in there as well.
Yeah.
And then, like it looks like there's necrosis adjacent to the ulcer.
Yeah.
Of the vessels, and then it seems like there are some like larger fibroblasts in there.
Something at least, larger something.
Larger
You're right.
cells.
There's some
scattered.
big guys in there scattered around.
Yeah. That was kind of the first thing that jumped out at
Good.
me.
Very atypical. I mean, really
Yes.
hyperchromatic pleomorphic cells scattered in here. What else? What about this?
Well, there's kind of more sclerotic collagen
Yep.
in there, and then the vessels there, little proliferation.
Yeah.
Telangiectatic vessels.
So what kind of thing would you think of? It's hard without any history.
It is.
Is there anything that comes to mind with these collection of features, this constellation of features?
That constellation would bring to mind like a radiation dermatitis.
Good. Now, I don't know if that's what it is, but that right away is the top choice of my differential is ugly but scattered fibroblasts, really hyalinized collagen, and dilated telangiectatic vessels with variable degrees of different change in the epidermis. Sometimes you have total atrophy of the epidermis. Sometimes there's sponge. Sometimes there's ulcer. It can run a wide range. I knew I could say it with practice. Yeah. So, and occasionally it can be a little hard. You start worrying like, gosh, could this be like a poorly differentiated spindle malignancy? Especially when I've seen like sarcomatoid carcinomas or sarcomas that are radiated, and then later there's a nodule there and there's an ulcer, and the question is it recurrent or is it all radiation change? And it can get pretty dicey. I mean, some like this one looks pretty good, but I've seen some times where malignancy kind of looked like this and it was just sparse, and it can be very challenging. I do find cellular to be one of the most helpful features. Really sparsely cellular tends to make me favor radiation, but I've had times where I just said, I'm just not sure. I don't know. And I favor this, but I'm not sure. And I want you to follow up and make sure. Radiation can make it really challenging to read the pathology on future specimens from that site. So let's see what this is called. This is called on a forehead after radiation exposure, radiation dermatitis. Well done. Well done. Very good. I also feel like you get a little bit of, sometimes can get a little similarity of changes in the setting of like chronic lymphedema, although not nearly as dramatic as this, but you can start to get sclerosis of the dermis, some larger, not usually that ugly fibroblasts, and dilated vessels. So that's another time I've occasionally seen things that I thought might be radiation and end up just being really bad lymphedema, or sometimes lymphedema and stasis kind of combined, like on the lower leg. So I've been tricked by that before. All right, good. Radiation derm.